items. The restrooms are located on the right side of the hallway, outside of this sacristy, about 50 feet down the hall on the right. As you probably are aware, we're an all-volunteer organization. Our work at the farm is guided by our desire to help men with prostate cancer and their families. Murray Barton is one of those individuals who is making a difference. Maury will share some of our resource needs that enable us to continue with our mission. I might add, Maury has been an advisor for only 7 months and has made some important contributions to the farm and its membership. He is the facilitator for the reoccurring advanced PC meeting. This is spearheading the design of a new brochure, is acting corporate secretary, and Murray is always there to help people with their questions and concerns. Maury will now say a few words.
Thank you, Larry. I just want to take a minute of your time, Doctor, to let you know that the Prostate Forum has been, as you may already realize, around for quite a long time, 25 years. And some of the people, if you go look at our website, I think Larry's been around for how many, 20 of those years maybe, in the pictures. And so we have, thanks, like any organization, we need some help now and then to do all the things we do. And I made the announcement at our earlier meeting a couple months ago that we could have some helpers. I said, what do you guys need to do? What do you need help in doing? So we made up a list here. And so my wife's going to help pass out the list, I think, put her to work. And we'll just want to give you a copy. My name's at the bottom, and Larry's name is at the bottom. And here, we'll give those to her. Let me start these at this side. So if you'd like to help in any way, just contact us. There's just a lot of things we do to facilitate having this meeting. And as you may notice tonight, we don't have our usual guy setting up all the books and pamphlets and handouts that we have in the back. And that's because his wife is having some severe illnesses, and he's getting older too. So we invite you to come and help. You don't have to have any particular knowledge of what we do, but we have people that will show you what to do, and so we can keep the organization healthy. So I think Larry comes back here in a minute. We'll go ahead and get started. Like I say, there's a list of all the different things we do, and thank you, Larry.
Thank you, Maury. If you have not signed up for the membership, please see the receptionist at the welcome desk immediately outside of this room. Becoming a member will automatically notify you of scheduled speaker presentations and other important events and information. All of the services are free. However, we do pass the basket around to partially cover our expenses. Could someone pass the basket around? Ron, could you see if there's a basket in the closet, please? See if we can't find a container here. Apologize here. Without further delay, let me now introduce our speaker. A board-certified medical oncologist, Mark C. Scholz, MD, serves as the medical director of the Prostate Oncology Specialist in Marina Del Rey, California. A medical practice exclusively focused on prostate cancer. He is also executive director of the Prostate Cancer Research Institute. He received his medical degree from Creighton University in Omaha, Nebraska. Dr. Scholz completed his internal medicine internship and medical oncology fellowship at the University of Southern California Medical Center. Dr. Scholz is a strong advocate of patient empowerment. He is the co-author of the book Invasion of the Prostate Snatchers. No more unnecessary biopsies, radical treatment, or loss of potency, and has written and produced extensive educational material on the subject of prostate cancer in various medicine medias, which includes DVDs, blogs, newsletters, and pamphlets. He is frequently an invited guest in the community at prostate cancer conferences and prostate cancer support groups throughout the world. He is also an educational speaker on behalf of Amgen, Dentron, and Sonovitus. He continues as a primary investigator, actively supervising a number of ongoing prostate cancer clinical trials, and has authored or co-authored over 90 scholarly articles and abstracts in the area of his expertise. Dr. Scholz's topic tonight is 5 stages of prostate cancer. The elements of his topic, 5 major stages and 15 subtypes of prostate cancer, life-threatening prostate cancer versus benign prostate cancer. Receiving optimal therapy depends on matching an appropriate treatment with correct stage and type of prostate cancer. I might add, Dr. Scholz is one of the most requested expert prostate cancer doctors appearing before the general membership. And besides that, he's my doctor. Please give Dr. Scholz a warm welcome.
Hi everybody, thanks for having me. It's good to be here, and I'll just carry on with my day talking about prostate cancer, which is what I do all day long. Part of the reason for me coming out tonight to talk to you, obviously, is to help you understand prostate cancer better. And the other reason is that I was just completed a second book, and so the outline of the talk tonight follows the outline of the book that was just completed, called The Key to Prostate Cancer. In fact, I have a picture of it here. I don't know if these slides with this much light are going to, might have to make me less beautiful so that the slides are more visible. And so, as Mr. Barman shared, the gist of our talk tonight is about figuring out exactly what type of prostate cancer you're dealing with, because the treatment changes depending on the type of prostate cancer. And it turns out that it's kind of difficult to get to exactly what type of prostate cancer it is. Do we have anything halfway in between? I want people to go to sleep on me here. I guess it's all or none, isn't it?
There's probably a halfway, but we don't know it.
That's probably good. Thank you. So, there's a lot of barriers between people, finding out really where they fit in the prostate cancer spectrum. In fact, I run into patients that don't even know there's a spectrum. They still think prostate cancer is one thing. And that obviously creates a real problem for people when they have misconceptions like that. That's pretty good. I like that. Beautiful. So some of those problems that people that are newly introduced to this and people that have been doing this a long time, is just the sheer amount of information. The staging system, which we're going to talk a little bit about tonight, you're going to see it's complex. But one thing that the book does is try and make that accessible. I like that too. That's nice. this is a high-stakes game because the treatments can have some nasty side effects. And as you all know, no doubt, the doctors that work in the prostate cancer world are mostly about doing one thing. Either they want to do surgery or they want to do radiation. So it's not a level playing field. They really, if all things are equal, a surgeon's going to want to do surgery. And so that tends to tilt the field. And really there aren't experts who are trained in figuring out what the best treatment is. There's a lot of doctors that pose as experts at figuring out what the best treatment is, but there's really no doctors that are actually trained in that specific role. So there's a lot of problems here. And so the book was written to address that. It was written for patients to be able to figure out on their own what stage they are, and then the book guides patients then to the section of the book that has information about the treatments for that stage. And as we go through the talk, you'll see how that works. But even though the book approaches 500 pages long, the average patient looking at just a section about his stage maybe only would have to read 150 pages of it, something of that nature. So it's actually shorter than it looks because of everything is focused. And we talked about different barriers. One of the biggest barriers I find in this whole process of trying to sort through a complex staging system and all the different challenges that I just outlined is that when people are really anxious and fearful, they just can't think objectively. And the whole idea of cancer is frightening. The idea of being permanently damaged by treatment is frightening. The treatments themselves are frightening. And the word prostate cancer is frightening. So the only way that I've found to try and compensate for these fears is to try and give people a context and direction and knowledge about what's going on. Because when it's sort of a confusing mix of information, all the terrors can run rampant. Once people start to get a handle on what it is and what needs to be done, that really helps quell the fears. So half of my job is guiding people to what the right treatment is, and the other half of my job is to calm people down and try and get them out. You know, they're hugging the tree and they're just so terrified. Literally, people will come to my office, they'll be shaking with fear. And after we sit down and talk to them for a while and explain what they have, where it's going to, there's like a peace and a calm that will come over them because there's some clarity about what it really means. And it's not just a bunch of vague, terrifying fears. So let's look at one of the fears, of course. Anytime when we hear the word cancer, the big issue is about dying. When we talk about lung cancers and pancreas cancers, people can be dead from those horrible illnesses within 6 months. And that's obviously what comes to mind first when we hear about those terrible things. Prostate cancer isn't like that. One of the advantages of a staging system, of course, is that we divide prostate cancer into 5 stages, 5 different colors, is that it gives you some insight as to where you fit in the spectrum of risk of dying. And as you can see, there are types of prostate cancer where there's essentially no risk of dying. So how important then is it to know where one fits in this scale? It's extremely important. Now, it's not only an issue of dying from prostate cancer, but with prostate cancer, one of the things that distinguishes it from all the other cancers, like pancreas cancer, lung cancer, that can kill people within just a couple months of diagnosis, is how slowly prostate cancer moves compared to all the other cancers. This is a very unique aspect of prostate cancer, and it's hard to conceptualize, honestly, the long periods of time that are required for prostate cancer to create a problem. Now, this is not to say that it's not a problem with something that is potentially deadly, but there's a big difference between something that's potentially deadly within 2 months and something that's potentially deadly within 20 years. It's a big difference, especially in the age group that we're dealing with, where the average man is in the 65, 70, 75 age group. Not all men are that old, but many of them are. So the pressure on patients with prostate cancer is decidedly less. I mean, look at these numbers, they need to be highlighted. So every year in the United States, 67,000 men are diagnosed with prostate cancer. Some of those men didn't check PSAs. They'll come into the doctor's office, their PSA will be 500. They'll have a bone scan that shows metastases at the time of diagnosis, already advanced. That's included in the 160,000, 170,000 men. There are men like that diagnosed. Including all of those men, plus of course the very harmless types, which we've talked about, their 5-year survival for all 160,000 men is 99%. 5-year survival for all types of prostate cancer is 99%. Okay? 10-year survival for all types of prostate cancer, including advanced prostate cancer, 98%. Okay? This is the sort of information that we have to let sink in because it's so different than what we normally would think of as cancer. Now, if you're in the 2%, you're dead, okay? I'm not trying to say it's not an issue, right? It is an issue, and it needs to be addressed, but it's not addressed with the same urgency as some poor person who has lung cancer, colon cancer, or pancreas cancer, stomach cancer, bone cancer, okay? It's a different type of situation. Now you get out to 15 years, you can see the disease is starting to rumble a little bit, and then beyond 15 years. So, but overall mortality from prostate cancer, 15%. So 85% of men that are diagnosed with prostate cancer will never die from prostate cancer. Okay? So it doesn't mean they couldn't be miserable from treatments. It doesn't mean that they couldn't have a lot of scares along the way, and there's a lot of problems that we need to talk about. But this is a different type of cancer than what we normally think of when someone says the word cancer. So if we know our stage, and we'll go through the whole process of these different stages, that's what the talk is about tonight. It allows us to determine how severe the cancer is. It allows you to come to the doctor's office with some sense of, you know, like when I go to the mechanic and my car is misbehaving, if I can tell the mechanic, hey, it's the carburetor, I know I've had this problem before, it advises the mechanic, hey, this guy, I can't sell him a new muffler, and so I'm gonna, this guy knows what he's talking about. Same thing with doctors. You walk in and you have a sense of what your stage is, you're speaking their language, you're going to get better service from the doctor. Obviously it guides you to the right treatment, and when you know the right treatment, you can also start anticipating the type of side effects that that treatment might cause. And very importantly, you don't have to learn about all the treatments for all the other stages, because it's a vast field. There's already too much information. So these are the 5 stages. We named different colors. It makes an acronym STARE. So this is advanced. These 3 are newly diagnosed with very trivial disease, sort of a moderate, and then a more advanced type of prostate cancer, newly diagnosed for these 3. And then these people have been through surgery or radiation, and now their PSA is rising. We call it indigo. We'll go into this more. So how do the complexities of it, you don't really have to understand how all the staging meshes together. We've created a simplified quiz or system for people to be able to determine their stage quite easily. And if we didn't do that, you'd have to fish through this type of stuff, because this is the nuts and bolts of what staging is about. There's basically 6 different factors, and depending on how one answers, or whether they have a Gleason 6 or a 7 or an 8, that's going to create different stages depending on how high the PSA is, 10 to 20, or over 20. And when you start getting all 6 of these things like a grid, you're getting complex. It turns out that the system is very effective at assigning people risk and stage, but figuring out what your stage is not easy. And so what's useful about the book, and this same information, by the way, what is in the book was truncated, abbreviated, and donated to the PCRI. So on the PCRI website, there is a synopsis of all this information, and there is an electronic way you can take this quiz that I'm going to quickly review for you. So you can figure out online free of charge. The guide is free of charge from the PCRI. So, so while the book is for sale on Amazon, the information, the guts, the essence of the book is free at the PCRI, as well as this quiz, which we're going through right now. So what is the quiz? Just briefly, it is answers to 6 relatively simple questions. So the online format, or in the book, you can fill it out with pencil and paper. A scoring system is created, and when you go through and you answer these questions, and I'll just list them really quick. What was the PSA at the time of diagnosis? Question 1. What was the highest Gleason score? What does the digital rectal show? A small nodule, a larger nodule, or a large area of cancer? Do you have any scans showing cancer outside the prostate in these locations? So you have to get the actual report, look at it from your chart, obviously. Have you had any previous surgery or radiation? Yes or no? And do you have a rising PSA while on hormone blockade or with a low testosterone? Yes or no? So if you can answer those 6 questions, and the information will be available in your medical chart, you can actually calculate your stage. It's done automatically online at the PCRI.org and the PCRI website. So I'm not going to go into the specifics of calculating that for you. It's actually so simple and straightforward. If you go to the PCRI website, you'll be able to figure out your stage. The rest of this talk, I'm going to just go through and give you sort of a sense on how these different 5 stages are treated, what they are and how they're treated. And with each of the 5 stages that we're going to cover, I'm going to also share one slide that has new information about treatment of that particular stage that's just come out in the last couple of months that I feel is very relevant and needful for that stage. So we'll go through and talk about what the traditional standard treatment is for these stages. We'll talk about the subtypes that are in the stages, and then we'll go through and talk about one new thing that has come along in the last few months that I think is exciting. So the first stage we're going to cover is what we call SKY. It's also known as low-risk prostate cancer. This is the harmless genre of prostate cancer, and it's hard to believe, but of the 160,000 men that are diagnosed in the United States every year, about half of them, 80,000, this is the biggest subgroup, are SKY. In other words, 80,000 men that are diagnosed every year are eligible to simply monitor their relatively harmless prostate cancer. So what defines this? Well, the specifics are that the Gleason score is 6, PSA is less than 10, they can't have had any previous surgery or radiation, and it's state-of-the-art imaging with an MRI that won't show any high-grade spots. That's what constitutes SKY. Now, there are subgroups of SKY, and we talk about the 3 subgroups within each of these different colors, shades of blue: low, basic, and high. The distinctions with SKY have to do with the results of the biopsy. As you might imagine, it's a little different when a person has 12-core biopsy and only one little speck shows cancer versus all 12. Those are 2 different situations. And so I won't go into all the details with great precision, but it turns out that there are some differences between people that just have a little bit of cancer on a biopsy core versus those that have a lot of cancer on a biopsy core. But as it all shakes out, for the treatment, doesn't really change. All of these men, even with a small amount or a large amount of grade 6, are eligible to go on monitoring, what we call active surveillance. And so this is obviously growing in popularity as people are getting comfortable with the idea that something called cancer is indeed safe to watch. And the statistics as of 2015 indicated that of the 80,000 men who are eligible for this, that have grade 6, about 40,000 were put on active surveillance in the United States in 2015. And it's probably better than that now. 10 years ago, 12 years ago, 1% of the men were put on active surveillance. So this is new. And it's hard for people to get their minds around this idea that, well, you know what happened? Someone really screwed up and called something that wasn't a cancer 25, 30 years ago. And so now we're unwinding from that gigantic mistake. So all of them are eligible for surveillance. And the new slide, I said, for each of these different stages, we're going to talk about one new development. And the big new development for the men that are on active surveillance is that instead of having to be monitored by going back to the urologist for another 12-core biopsy every couple years for the rest of your life, now you can do an MRI with peace of mind that it's more accurate than the biopsy. So MRIs can be substituted for biopsies safely, and this is a very exciting development because it allows many men to just do the MRI and not even get a biopsy. If the MRI shows a trouble area or a worrisome spot, a targeted biopsy with only a couple of biopsies of the abnormal area is adequate. So rather than having a dozen or more needles stuck in the prostate, men can get by with maybe a couple to make sure that there's nothing bad happening. So this is a gigantic advance. I'll say publicly that my favorite place for MRIs in Southern California is at UCLA. There is a skill factor to doing MRIs well, and in my opinion right now, they've made the deepest commitment towards getting high quality MRIs done. And so we almost universally have all of our patients go to UCLA to get their MRIs. And we do them a lot because we have a lot of men that are under monitoring. So this is a very exciting development. This article published in, where's my color here? Here we go. New England Journal of Medicine, most prestigious journal in the world, and it just came out in March. And so this is very exciting new news. And now all the urologists are going to stop doing 12-core biopsies and do MRIs, right? Why not? I mean, it's science. This is proof, right? Yeah, the problem is that someone spoke body language to me. He went like this. The problem is that the doctors, the urologists, aren't paid to do MRIs. They are paid to do biopsies. In some of the large centers, they actually charge by the core. So this is a big hit in the pocketbook for them to say, we're not going to do a biopsy on you, we're going to do an MRI on you. So patient awareness is starting to change this. So patients are starting to see, our practice, we're seeing people all over the country coming to us when they hear about an alternative to having their poor behind harpooned a dozen times. They say, yeah, I'll get on a plane, I don't mind. And so they come from all over the country now to get an MRI. But they don't even need to come to us. They can get a good quality MRI in many places in the country now. But it is new, and people are their doctors are saying that they're frightened by the prospect of not doing it. But people are comfortable with the way it's always been. I mean, that's a normal human reaction. It does take time for new ideas to penetrate. And, but this is penetrating pretty quickly because of the huge difference between getting a biopsy and getting an MRI. And now we know the MRI is more accurate and certainly less dangerous. As you're probably all aware, anytime a biopsy is done, there's a risk of serious infection. And that can be avoided. So, all right, very exciting development. That's about Sky. If you look at the side effects, from a biopsy, you can see that the men that went through the MRI and had far fewer biopsies have much less bleeding, they have much less pain, and of course, they have less erectile dysfunction as well. All good things. All right. So we're going to move on now and talk about teal. That's what we call the intermediate risk patients who are diagnosed with prostate cancer. And they're characterized by having a Gleason 7, or a PSA between 10 and 20, or if there's a finger exam that shows a bump, it's not a very big one. So those are the type of men that would be in this category. I'm not asking you to use this information to figure out if you're teal or not. You really need to go on to PCRI.org and punch in the numbers precisely. But this is the general range of what's going on with someone who has teal. And this also is important to divide into 3 subtypes. And the patients with low, basic, or high-teal. There's 2 types of 7. 7 is broken down into either 3+4 or 4+3. So when they do the biopsy, what looks like a grade 4 under the microscope is quite different from what looks like a grade 3. So if there's more 4 than 3, you're in a high-teal. If there's more 3 than 4, you're in a low or a basic-teal. So the other distinction between the low and the basic-teal really comes back to how many needles have cancer in them. So the old random system is, a lot of this is built around that old random system. People get a dozen cores, and then 2 of them show cancer versus 5 versus 9 versus all 12. You can see how that would have a powerful predictive factor in determining how risky the status is for that patient. So what are the treatments for these low, basic, and high teals? Well, good news is that the low teals can also do active surveillance. So men with small amounts of grade 7 are safe for doing active surveillance, just like all the men that we talked about before that have grade 6. The men that have the basic teal, that's a 3+4 with relatively few cores, a few more than this, but still less than half of them. Most doctors are recommending some form of treatment, but just one treatment. Maybe a seed implant, maybe some radiation, if you're a masochist, surgery, or even just hormone treatment. The high-teal, this is starting to get, this is where patients have a lot of cores, they have a 4+3. This is starting to get more dangerous, and the standard recommendation is a combination of seed implants, external radiation with IMRT, and a course of hormones for 4 to 6 months. Okay? So even within teal, you can range from active surveillance to combination therapy. This is a big transition, this whole teal category. Very important that you know where you fit in here. So what's new for the teal crowd? Well, this recommendation here is still considered standard throughout the country. But there's a new study out now that raises the questions whether even the high-teal patients can get away with a seed implant alone. Seed implants have been sort of the poor cousins of the treatment world, partly because of the random way that payment is set up. The doctors that do seed implants don't get paid anywhere near as much as the doctors that do beam radiation. So a lot of the doctors that used to know how to do both gave up on seed implants. They say, if I'm going to get paid 10 times more to do beam radiation, why would I ever do a seed implant? Well, now studies are coming out just in the last couple of years, and this is one of them, showing that because the seed implants can deliver a higher dose of radiation into the prostate, they have higher cure rates than the other types of radiation. So slowly but surely, the facts and the science is driving the medical world back to the seed implants. And this is one of the studies that just came out in November of 2017 that looked at 3,700 patients at Harvard, and they compared seed implant plus radiation plus hormone blockade. Remember, that was the treatment that I said is standard for high-teal, right? They compared that standard approach to just a seed implant alone. Cure rates were the same. That's exciting because the side effects of a seed implant alone are a lot less than having to do beam radiation and hormones too. So this is not very exciting for the doctors that do beam radiation. No one wants to talk about it too much. Because they've really built, the system out there has been built up around beam radiation. It's one of the most lucrative areas of medicine. Medicare pays something like $26,000, $28,000 to do beam radiation on just one patient. So and the seed implants are nowhere near that. So this is a skilled procedure. The doctors, many have forgotten how to do it properly. And so it is important that if you go this way, that you go find a doctor that is very dedicated to doing it, and that's a big part of their practice. They're out there. Okay, so we're going to Move on to our third stage, the Azure stage, or high-risk prostate cancer patients. These are the men that are newly diagnosed, but they've got a higher Gleason score and or a high PSA, or they've got an MRI imaging study that says there's cancer growing into the seminal vesicles, that's outside the prostate, or even some enlarged lymph nodes down in the lower pelvis. So this is a much more serious type of prostate cancer, and understandably then you're going to talk about much more aggressive treatment. If you look at the high, remember to divide these into three, low, basic, and high. So High-Azure, these patients are going to get a combination of, well, this just defines the difference between them. Let's go on to that first. The High-Azure, they're going to get not the same as Basic-Azure, in other words, seed implants, IMRT, and hormone therapy for 18 months, not for 4 to 6 months like the Teal, but long-term hormone therapy. And when you get into the High-Azure, you're going to be adding some of the new, more potent hormones like Zytiga, Xtandi, and maybe even a course of chemo. These are the ones that are the most dangerous of all for the newly diagnosed. So how do you separate these three out? Basically, the Low-Azure patients, they have a grade 8 tumor, but everything else looks good. PSA is low, only a couple of cores. These patients behave very similar to the High-Teal patients. So they can get away with less treatment. The basic treatment for these guys is pretty much everything between these two extremes, and they're the ones that I told you before. They get Seeds IMRT and 18 months of hormone treatment. So what's new with the Azure patients? This Journal of American Medical Association just came out 2018, this year. High-risk patients is what we're calling Azure. Surgery, IMRT, or the combination that we've been talking about. This again demonstrates the power of seed implants. If you look at this is the 7.5 years mortality rate. Now, when you get into Azure, people, this is the group of people that causes most of the mortality. Very few patients with Sky or Teal are dying of prostate cancer ever, let alone within 7.5 years. So you're looking at, this is the problem, this Azure category, especially the High-Azure category, are the ones where you're saying, people are dying. And look what they're saying here, 17 out of 100 men that had surgery died. 18 out of 100 that had hormone blockade with IMRT, no seeds, were dead from prostate cancer. Okay, this is not everybody, but this is a significant chunk compared to the other types of cancer. But look at if you put the seed implant in here, the mortality rate was almost half of what it was with people that had surgery or IMRT. This is amazing data, and it doesn't come as a surprise to me because of what we know about seeds being able to deliver a much higher dose of radiation into the prostate than IMRT can accomplish safely. So this shows that what we found out with seed implants tonight is with the Teal category, seeds alone might be enough. And what we find out with the Azure category, that going without seeds puts you at significantly higher risk of dying of prostate cancer. That's pretty amazing. It's not a small difference. You're looking at what, about a 40% difference in mortality rate. All right, so now we'll go on to indigo. Indigo is a unique stage for prostate cancer because of PSA. PSA, rising after surgery or radiation, the doctors have learned over the last 20, 30 years, means that the cancer is coming back. And for years, we didn't really know where it was, but we knew we could trust the PSA. If the PSA was rising, sooner or later, the cancer was going to show up. Data later showed that how fast the PSA is rising gave you an even better insight as to how serious the situation is. You can imagine that PSA is going up very rapidly. This speaks of a cancer that's growing rapidly, and that's more dangerous. PSA that's rising very slowly, a less dangerous type of prostate cancer. So other cancers, colon cancer, lung cancer, all these cancers, they don't have PSA. And so what they would do to monitor people after an attempt at cure with surgery or radiation is they would get scans every 6 months for the next 5 years looking for metastatic disease. But when a man develops a rising PSA after surgery or radiation and scans are done, there is no metastatic disease. So you just have this rising PSA. It's kind of a twilight zone of recurrent cancer. And this is very common. About 60,000 men a year who have undergone previous surgery or radiation develop a rising PSA, and they're in this indigo category. So so a rising PSA without proven metastasis is the sort of the main idea of indigo. Once again, we have different types of indigo, and due to different calculations, you can look at whether the doctor thinks that the cancer is right where the prostate used to be, or if they have radiation maybe in the prostate. That's a type of low indigo, okay? If there's a thought that or if there's proven spread into the lymph nodes right around the prostate, that's a high indigo. And if different factors lead to the doctors to think that there's probably spread around the prostate, even though we can't see it, that's called a basic indigo. And of course, as you can imagine, each of these categories are treated differently. The patients that they think the cancer is right where the prostate used to be can be cured with some radiation to that area. Very simple. The patients that have proven spread into the lymph nodes, now you're dealing with a cancer that is shown beyond a doubt it's dangerous. It can spread. It's in the lymph nodes. So we know that the biology of that cancer is life-threatening. And experience has shown that aggressive early intervention with maximal treatment gives the best chance for long-term survival. And so those patients with high indigo, usually you're throwing just about everything in the kitchen sink at them. Patients that are in the between status where they're thinking, well, maybe there's something in the lymph nodes, a sort of an in-between intensity of treatment is used. So amazing new breakthroughs are happening in this indigo stage. As I mentioned before, this concept of a rising PSA, but all the scans being negative, has been what I've lived with through most of my career. And typically, the PSA would have to rise up to, say, 15 to 30 to 50 before we could find a spot of cancer. Because the scans were basically that crude. We didn't know where the cancer was coming from. We were guessing. Now, with a new type of PET scan, and maybe you've already heard of this, some of you, this was just published in European Urology this year, in the last couple months, a type of PET scan called PSMA PET scan. This is available now to patients who are willing to pay $800 and fly to San Francisco. At UCSF, they're selling this scan. UCLA is selling this scan, but it costs about $2,500. So the amazing thing about this scan is they can find the location of the cancer when the PSA is less than 1. This is totally revolutionary. We never had anything like this before. So in this particular study, they reported that if patients had PSAs under 1, or excuse me, less than 0.5, less than half of 1, they could find the cancer in slightly more than half of the men with the scan. And if the PSA was between 0.5 and 1, just under 1, 3/4 of the time they could find where the cancer is coming from. So what does this mean? This means that it's possible to find the cancers and zap them with radiation and possibly cure the cancer, even if it's already spread. We've never had that capacity before. So this is like, I don't know how to put it into words, totally revolutionary. So the scans have been out for a while, but we haven't had a quality report like this to show that in a large, 272 patients, a large study, prospective study, there were suspicions that these scans were this good, but this really shows the performance of the PSMA PET scan. So anyone that has a rising PSA after surgery or radiation is wondering where the cancer is, this is how you go. It's like a no-brainer. All right, this is an older type of PET scan. I think it might be more confusing than helpful, so we'll just skip that slide. Last color that we're going to cover, the royal stage, is patients that have one of two things. Either they have proven metastasis on a scan that's outside the pelvic region, so not in the lymph nodes right around the prostate, that doesn't count, but anywhere else in the body, in the bones, in the lymph nodes up in the abdomen. I don't know what I did there. Those patients have what we call royal, or alternatively, patients that have been on hormone treatment for a period of time and it stops working. How do we know it stops working? PSA starts rising while the hormone therapy is continued. Hormone therapy will make the testosterone levels drop below 50. So a rising PSA with a low testosterone, usually from being on Lupron or a shot, hormone resistance, that's a sign of royal. Why is that such a serious development? Well, if you think about it, hormone treatments are the most effective treatment for practically any cancer that's ever been known. If we put an indigo patient on Lupron shots, the average response time is 10 years. There's nothing like that for any other cancer. It's amazingly effective. Doesn't mean it's without side effects, but it's amazingly effective. So if your best treatment starts to go belly up on you, that's serious, because patients have been riding that horse, and all of a sudden that horse isn't going to carry them any longer. So the development of hormone resistance is a very serious development. Obviously, having metastasis in the bones is serious, and of course, some patients can have both of these things. So again, we divide these men for the sake of treatment, for allocating treatment, into three categories, and it is divided according to how many spots or metastatic spots are present. We've learned through experience that some men that just have a few metastatic spots can be treated with radiation treatment to those spots, practically no additional side effects, and get long-term control of their disease. So patients that are not eligible to do that, the ones that have more than 5 spots, are what we in the high royal category. If patients have metastatic disease, but it's 5 or fewer, they're in a more favorable group called basic royal. And then there's a category, which is not that uncommon, where men who've been on hormone treatment a long time, they may have had surgery 10 years ago, they put on hormone treatment, their PSA's been 0, but now it's starting to creep up. And of course, a lot of this data precedes those amazing new scans, right? So I told you that the PSA may have to rise up to a certain level before a scan will show anything. There's sort of no metastasis, but clearly because of the rising PSA, they have a hormone-resistant status. That group is what we call low royal, and I think I'll just skip this because I want to go to the new development. This is published again in the New England Journal of Medicine in February for this low royal group. Where's my pointer? Here we go, sorry. February, New England Journal of Medicine. For the people that develop a rising PSA while they're taking hormone blockade, historically there wasn't a lot of treatment recommendations from the American Urologic Society and the American Cancer Society and whatnot. They sort of said, well, just sit tight, wait for metastasis to occur. I mean, patients didn't like that idea, but there weren't any specific medicines designed to treat those people. But Janssen Pharmaceuticals did some studies with a pill, a supercharged hormone pill, administered to these men at the time of rising PSA, when the Lupron stopped working, when they became what we call a low royal category. And so 1,200 men were put into this study, and a third of them got treated with a placebo, and a third of them were 2/3 of them were treated with this new pill. The new pill, interestingly, didn't have a lot more side effects than the Lupron. It's well tolerated. And what they did is they watched these 1,200 men to see how long it would take for a metastasis to appear. Because Because we know that the metastasis is going to come sooner or later. When people become resistant to Lupron, metastases are on their way because Lupron was keeping it in check. And so, yes, it's lo and behold, with the group that were put on placebo, let's see, we had 1,200 men, so a third of them is 400. So 200 of them had developed metastases within 16 months. Now, me telling you how prostate cancer moves slowly doesn't apply when people get resistant to Lupron. Okay, it has been moving slowly. It often takes 10 years for people to become resistant. But once that happens, things change. Now we're dealing with a very serious disease. Half the men developing metastasis within 16 months if they're not treated. The patients that were put on the new medicine, half the men developed metastasis, but it took 40 months instead of 16 months. Quite effective, and really no additional side effects of note beyond the, I mean, they're listed here. We have a few rashes, some tiredness, a little high blood pressure, and a small percentage of the patients. So a remarkable breakthrough, again, just within the last couple months this came out. This is FDA approved now, and very exciting. So summary of the talk, staging the disease, knowing what you're treating is how we combat fear of uncertainty and of making mistakes and all the different anxieties. Patients need to be familiar with the therapies that are appropriate for their stage. So when they're discussing their treatment with their physician, they can talk from an intelligent point of view. And also, of course, just talking to just one doctor is not usually prudent. You want to talk to several doctors from different specialties and use the information that you have wisely. So this is summarized in this book in detail. It's also available online at the piece. Right, Alex, do you want to stand up a minute and tell them about your website? And I didn't warn her I was going to do this, but I'm tired of talking, so come on up here, Alex. Alex runs the PCRI for me, and she has put together an amazing website. And why don't you just take a minute and talk about that while I rest my voice.
So in the previous slide it said you can go to pcri.org, so that is our website. There's information in the back. You also may have the staging guide. The staging guide comes in the PDF version. This gets updated basically at this point every 4 months. We have a new update coming out next month, so it'll include our Lita, which you just spoke about. But our website has multiple different types of media in order for you to be able to digest prostate cancer information from articles, videos, graphics, whatever it is to help you learn about prostate cancer. And so once you take that quiz, it'll take you to your stage and the treatments that are associated with that, the side effects. And if you have any further questions about those or any concerns, we have a helpline that runs throughout the entire week. And they can answer by email or by phone and talk you through the process. It's all free. Graciously, people who have donated would be able to do this for a very long time, 22 years. And so it's somebody to kind of guide you through the process and help you have those conversations with your doctor, and then print out information to take to your doctor saying, look at these treatments and look at this medical, evidence-based medicine that you need to pay attention to if they're not listening. And so that's what we do on a constant basis. We have conferences twice a year if you want to be able to talk to the experts who are the experts in their field in these treatments. And yeah, so that's what we do. And our website is fully built out for that. And if you need anything, you can always let us know and contact us. And we have Dr. Scholz here to answer further questions.
The guides here.
The guides are in the back.
So I see one here. Did they get passed out, or?
Yeah.
So do you want to tell them what they have in their hands?
So basically, it is this talk in basically a guide form. It's about 80 pages long. It's a condensed version of Dr. Scholz's book, The Key to Prostate Cancer. It's free. If you contact us, we can get you more for your friends or anybody else. There's also the PDF version online. But you can take the quiz in the beginning of the guide, and it will lead you to 3 sections. Well, the first section is kind of the basics of prostate cancer, what you need to know in regards to PSA, Gleason score, what all of that means. The second section it's going to lead you to is actually your particular treatment. So Sky-Teal is where to go and Royal and where you're at. And then the 7th section in that, the 3rd section for you, it's all the way in the back, 7th section. Our guide for the entire guide is men's health and anything associated with that with supplements and nutrition to kind of do the overall health as well. So yeah, it gets updated every 4 months. We'll have a new one for you in a couple weeks, and you can get on the website and contact us, and we'll send them to Larry.
Scholz is going to entertain some questions. And so raise your hand, and then I will bring the microphone to you. I'll start over here.
Does patient age factor into the staging?
So absolutely patient age factors in. Obviously it's sort of an experience thing in terms of trying to decide when an 85-year-old can confidently trust that he won't die of prostate cancer due to the fact that he's not likely to live past 95 or 100, right? So since we're talking about a disease that can run over 15 to 20 years, it's only sensible to start thinking about the fact that someone can die of old age before the cancer can get them. So, for example, you may take someone who is 80 or 85 years old that has an Azure stage, a high-risk prostate cancer, and put them on active surveillance. Because worst case scenario, it's going to take 10 years for it to take them down. So that's a simple example. It's not always an easy thing because you always want to err on the side of, well, they may live longer than you think, right? So you have to calculate that into the whole equation. But age is a very important thing. When you're talking about younger people, let's say someone in their 40s or 50s, we don't necessarily think of treating them differently, but you realize that you're playing the game for higher stakes. Because if you screw up, you have more years of life that are potentially lost. So it's more important to be precise with younger people, but it doesn't mean that there's a radical difference in the way that they're treated as outlined here.
Why don't you go ahead and let me give him this, because he's
I
speaking
can
most of the
scream,
time.
that's okay.
You okay?
Yeah.
Dr. Scholz, I believe you stated that a multiparametric MRI can take the place of a biopsy, is that correct?
That's right.
Will that give you a Gleason score?
No. So multiparametric MRIs, when you do them, the readout will look for spots in the prostate. And there's a system called the PIRAD system, and they score the spots from 1 to 5. If a person has a score of 1, 2, and some say 3, it's so likely to be harmless that you can probably skip a biopsy, maybe do another MRI in 6 to 12 months. Patients that have 5s will need a targeted biopsy. So maybe 2 cores of the spot to find out what the Gleason score is. But that's a big upgrade from needing 12 cores that will probably miss the spot. All right.
You had mentioned there's a new drug called Erleada that's just been approved. Is that similar to Zytiga, and also are the costs for both of those drugs similar? Would you recommend Erleada before Zytiga?
Great question. So after Lupron stops working, there's a huge breakthrough when Zytiga and Xtandi came out. I think Zytiga was 2011, Xtandi was like 2012 or 13, because people that became resistant to Lupron could be put back in remission with these medications, miraculous medications. What's different about Erleada is not that it's any better or worse than Zytiga or Xtandi. What's different is that the company designed a clinical trial for a group of people that had never been tested before, the low royal group. And they demonstrated the amazing potency of this genre of medicine, whether it be Erleada, Xtandi, or Zytiga, if it's used at an earlier stage. So they have FDA, they're the only ones with FDA approval for use of this medication at that stage. I personally don't believe that it's any better or worse than Zytiga or Xtandi, although no head-to-head trials have been performed to prove that. Every time a new medicine comes out, it always is costs more than the last one. So, but they're all incredibly expensive. We're seeing pretty good insurance coverage for these pills, but we're talking about thousands of dollars per month for these medications. Wow. Very expensive. One hopeful thing on the horizon is that Zytiga, one of the 3 pills that we've been talking about, Zytiga, Xtandi, and Erleada, is going to go generic in probably sometime in the near future and will become far less expensive.
Raise your hand if you have a question.
prostatectomy in 2005 at City of Hope. I've been on Lupron and Zytiga and ABT 888, a PARP inhibitor from the University of Michigan clinical trial. My PSA is 0.008, and my testosterone is 12 to 15. And my concern is really how much longer do I have to go before, nobody can tell me when Lupron's going to stop working, but what do I do after it stops?
Well, no one really knows. These are new medicines. There's a when you achieve what is called a complete remission, as you have, where your PSA becomes undetectable, it is possible that you will remain in a complete remission for the rest of your life. We don't know. Not everyone will, of course, but only the people that get their PSA to undetectable levels are those that can hold out hope of a durable, permanent remission. When you can't get the PSA down, you know, like trying to hold the balloon underwater and the PSA just will not go to undetectable levels, that's a sign that the treatment is not getting complete control of the disease. So, but when you achieve complete control of the disease, as you have achieved, we don't know the future with precision, but we do know that some patients like you can remain in remissions indefinitely.
But I have numerous mets in my bone structure as well.
You want to argue me out of that? Is that what you're trying to do?
Thank you.
Thank you, Doctor, for everything you do. Really appreciate it. Just a question. Is it University of California, San Francisco that does the PET scans?
Yes. UCSF, $850 for the PSMA PET scans. Yeah, it's the best price we know of, and we believe that they know how to do them well and accurately.
Do you have to have a doctor refer you to them, or can you?
I think you probably need a prescription, I would think, yeah. But I'm not sure of that. Maybe they'll just take your money.
Thank you. Doctor, what's an undetectable level of PSA?
It depends on, as you know, there are no real universal standards of PSA. So some PSAs will measure down to as low as 0.1, and some PSAs will measure down to as low as 0.005. So whatever assay you're using, there should be a less than sign in front of a very, very low number. That's undetectable. Patients that have an undetectable PSA at 0.1 with an older, less accurate assay may not have an undetectable PSA on a more powerful assay. But still, getting the PSA down to less than 0.1 is a very good thing.
You have your PSA done, ask the accuracy level. Okay, because there's different types of equipment that have different accuracy levels. Right here.
So there are certain tests like Decipher, Oncotype, Prolaris. Maybe it's a complicated question, but under which stages would they be appropriate?
So genetic testing is an exciting area of new development, and the ones that were just cited are used to help determine if men who are in the SKY category look very favorable, PSA under 10, Gleason 6, if they can safely stay on active surveillance. So I like the tests because they often reassure people and confirm that they do indeed have a relatively safe condition that can be watched. I'm not 100% convinced that every unfavorable genetic test that's done in those SKY patients means that patients should go on and do treatment. I think the problem is that a lot of the studies were done in men over in other countries where the cancers are worse and people aren't monitored as well. They're not treated as aggressively. And so sometimes I believe that the statistics reported from those genetic tests can be a little bit pessimistic compared to what I think is really going on. But when patients have these tests and they come back very favorable, it's a very comforting thing to get another layer of assurance that the cancer they have can be safely watched. So,
is there any one that's better than any other?
The Decipher, Prolaris, and Oncotype, I don't believe that I can point to one as being better or worse than the other two.
Thank you for your presentation. Can you give us an update or what your viewpoint is on what's happening in the world of immunotherapy, like Provenge?
Sure. So I think the best illustration of how the amazing advances that are being made in immunotherapy is this story of when we heard a year and a half, 2 years ago that President Carter was about to die from metastatic cancer to his brain. And yet we haven't heard about President Carter dying from metastatic. So he was put on one of these brand new immune treatments and apparently had an amazing turnaround. That, of course, has been the hope of immune therapy for the last 25 years. People didn't really understand why the cancer vaccines didn't seem to work very well. But they finally figured out what the problem is. The immune system is so powerful that it needs very tight regulation so that we aren't attacked, that we don't all develop rheumatoid arthritis and lupus and multiple sclerosis and all the dreadful things that an immune system out of control can do. And so various researchers figured out how to deregulate this regulatory component. That's what most of these new immune medicines do, and there's a number of them on the market now. And when you let the immune system do its thing, it can attack the cancer and it can cause amazing turnarounds. These developments are completely revolutionary, and what we're doing now to patients with cancers with these and all different types of cancers is very trial and error. They've discovered these medicines, but no one knows how to use them in an optimal fashion. And even though they're not being used in anywhere near an optimal fashion, people are getting amazing responses. Even with the doctors don't know what they're doing. They're just squirting this stuff into people, and good things are happening. So we're at the beginning of, I think the two big breakthroughs in prostate cancer are, one, the new scan, where now we can find the cancers when the PSA is less than 1. I shared with a slide tonight. And the other exciting area is the development of immune therapy. You mentioned Provenge. Provenge is FDA approved for prostate cancer. I believe that the future of immune therapy is going to be combinations of these Provenge plus these medicines that release the brakes from the immune system, plus other modalities used intelligently and properly. And one important thing to realize with this whole immune cancer fighting, one reason that these things are working so well is they discovered that the cancers are smart enough to exploit the regulatory system of our bodies and fool our systems into thinking that the cancer is not a bad guy. And so these medicines are undoing that faking out that the cancer is doing and allowing the immune system to get in there, attack, and kill the cancer. So it's exciting to be able to, I'm glad you brought that up, because the figuring out how to fix prostate cancer, when I just showed you, 15 different types of prostate cancer. But let me tell you that each of those subtypes, there's another 100 in each one. So the genetic diversity of prostate cancer is in the thousands and thousands of types. We're not going to be able to figure out a magic bullet for each one. But the immune system is smart enough to figure it out. The immune system is smart enough. So I think it's going to be the shortcut towards amazing progress in reducing mortality rates.
Actually, two questions. What do you, the first one would be about high-dose vitamin C drips. That's been recommended, and then also, I was reading something about cancer being identified not so much as some sort of a fungal infection. Do you have any opinions on that?
Yeah, those old wives' tales have been around for 30 years, and they haven't changed, and they don't have any more validity than they did 30 years ago. They're creations out of thin air. There's no science to support them whatsoever. There have been careful studies of vitamin C drips in colon cancer, not prostate cancer. without effect. And we've had a number of patients who've asked us to monitor them while they, because we don't do vitamin C infusions in our office. Very easy to do. I have an infusion center. But who have gone to other doctors to get vitamin C infusions. And it's a relatively harmless treatment, so I didn't balk or argue against it. Unfortunately, I've never seen a single patient ever respond. So I like, with prostate cancer, it's not particularly difficult to know what works and what doesn't work. When things work, the PSA goes down. When things don't work, the PSA goes up. So if I'd seen one patient in my career who went on IV vitamin C and their PSA went down, I would be very interested. I've never seen it. The whole fungal thing, really, there's just no basis at all for it. So it's, you know, there's a lot of people that prey upon desperate people with cancer and offer all kinds of loony solutions, and I believe that that's one of them. So.
Hi. Is the Axeman scan either discredited or superseded by the UCSF scan that you mentioned?
So the Axeman PET scan is, whereas the UCSF scan that we just talked about is not FDA approved yet. It's available, but it's not FDA approved. If it was FDA approved, the insurance company would pay for it. The Axeman PET scan operates under the similar premise as the PSMA scan that we just talked about, and it is FDA approved and it is covered by insurance. The reason that I point this out is that this turns out to be quite a bit more accurate than the Axeman PET scan. Now the Axeman PET scan, which is covered by your insurance, is far more accurate than the old technology where I've told you that the PSA had to be 15 to 30 before a CAT scan or a bone scan would show anything. The Axeman PET scan is picking up metastatic lesions with PSAs in the 3 to 5 to 10 range. So that's useful, and it is covered by insurance. But it appears that the PSMA scan is quite a bit more accurate.
Hi, Dr. Scholz. I'm just asking you about the effectiveness of Taxotere and how you determine if it's working or not working.
Same methodology. PSA levels should decline if a treatment is working. The exceptions to that are some of the immune treatments. It's a little confusing, and there's an injectable type of medicine called Xofigo, which has been proven to prolong life, but does not invariably cause a decline in PSA. So those are exceptions to the rule.
That's just for the bone system, though, isn't it?
That is correct. So, but the PSA as a methodology to determine if Taxotere is working or not is very accurate. So patients who, the threshold is typically to look for a decline. So say you start with a PSA of 100, you start on Taxotere. Studies show that if you can get a 30% decline in PSA, so if the PSA drops from 100 down to 70, that's going to translate into prolonged survival. So that is what you look for. Now, some patients will have far more dramatic declines in PSA, but the threshold for believing that it's effective is to get at least a 30% decline in PSA.
How would you compare the sensitivity of PSMA with carbon-11 acetate?
So there's a third type of PET scan that is, in fact, I showed a picture, we just jumped over it, but called C11 acetate. It isn't covered by the FDA. It costs about $3,000. It's presently available in Phoenix. There's a Dr. Fabio Almeida who does beautiful work. I strongly suspect that C11 acetate is probably about equally accurate to PSMA. And that, again, hasn't been proven or disproven. There are studies ongoing to compare these things. But and that's been available now for 3 or 4 years, and we've had a lot of patients go over to Phoenix to get that particular scan. And so, but now with the advent with an equally accurate scan for a lot lower price, up in San Francisco, people have been shunting up that way.
Yeah, I just had one more question. The combination therapy that people have talked about. What is your opinion of, Lupron and Zytiga, Xtandi, and Xofigo all used together?
I mean, combination therapy makes a lot of sense if someone's cancer is serious enough to warrant it. This is why staging is so important. Some people have a relatively modest, mild type of prostate cancer, and it's unfair to them to put them through the rigors of multiple treatments. On the other hand, some people have imminently life-threatening prostate cancer, and in my opinion, it's crazy to withhold any treatment because these treatments all have potential for prolonging life, and there's even a possible of what we call synergy between the treatments, where if you're giving 2 or 3 treatments at the same time, you might get more than an additive effect. You might get a multiplying effect against the cancer. So that policy, of course, can be limited by the fact that additional side effects occur when multiple treatments. So there's a skill factor in doing this sort of thing. But it's very logical to consider using an aggressive combination of treatments in the patients that have serious types of prostate cancer.
One more question.
This gentleman here's had his hand up a long time.
Oh, just, yeah, excuse me. No, sorry.
Real quick, thank you for your presentation. And does Keytruda have a place in prostate therapy?
So Keytruda is FDA approved to treat lung cancer, bladder cancer, not yet prostate cancer. We've done a lot of research with Keytruda in our practice, and we find that it does have activity. Keytruda, by the way, is the immune medicine that turned President Carter's life around. He had a melanoma. That's the third thing that Keytruda is approved for. So all the thing we said about immune medicines before, it's called Keytruda, or at least that's one of the names. So what we found, we published a study that looked at about 60 men that we treated with Keytruda, and it appeared to be active, and it appears to be a lot more active when you use it in patients that have earlier stage prostate cancer. That for whatever reason, as a single agent, the way we used it, if patients had very high PSAs to start with and extensive disease, the impact did not seem to be that great. But in patients that had lower PSAs, fewer metastases, that did seem to have notable activity. Yeah.
Last question, anybody?
So, if you have genetically correlated prostate cancer, I got 6 out of my 7 brothers, so that's pretty good, right? Would you recommend University of Washington, Seattle as the place to look at a situation, or is there a place in Southern California that
you want to do genetic analysis to figure out?
Well, I've already got the Polaris test ordered, so I'll have that information.
One of the problems with trying to determine your treatment based on what other family members have had is that if you go back and look closely at the other family members, you'll discover that they have different types of prostate cancer. So I believe that you want to do the best job you can at defining what you have and go with that.
Well, that's actually what I'm doing.
Yeah.
I had another question. Is it okay? Diet and lifestyle. For somebody on active surveillance, what is your opinion as to that?
Well, that's one thing. I was very hard on the fungal treatments and the vitamin C thing. But one thing that I've learned through direct experience through the years is that diet can have a big impact on how prostate cancer behaves. And if you think about it, after observing this in patients who got very serious, went on stringent vegan diets and controlled their PSAs for long periods of time, is that it's kind of logical because prostate cancer hurts people by growing and multiplying. So your body can adapt to a nutritionally deprived state quite nicely, and you may lose some fat, but your body will learn how to live within those confines. Cancer cells are just stupid, and if you feed them really well, they'll grow, and if you don't feed them very well, they don't grow as well. So when you take something like prostate cancer that can play out over a 10, 15-year period, and you say, okay, I'm going to nutritionally deprive this cancer for a long period of time, and you cut the growth rate by 50%, now you're looking at, instead of 10 to 15 years, you're looking at 20 to 30 years. Now, the hard part is the execution, right? Because there's a McDonald's on every corner. But so this was just clearly demonstrated to me in patients that came to me 10, 15 years ago and said, I don't want any of your modern Western medicine, Dr. Scholz, but I want you to monitor my PSAs. I'm going to go on a macrobiotic diet.
That's me. That's what I'm doing.
And the macrobiotic diets, when they're aggressively implemented, are scary to people because they cause people to lose a lot of weight. The family member all think that they're dying of cancer because they get very skinny and thin and there's no fat. But I'll tell you, those PSAs that were rising, all of a sudden they just level off and they just stay there. And then I discovered that even though the patients lose a lot of weight, they're feeling good. And other than the fact that they don't have a lot of dietary freedom, which is a bummer, they do quite well. They feel well, their energy levels are good.
I've heard, I don't know what macrobiotic diet is.
Just think vegetarian.
Okay, well, okay, then I do that. But I heard Dean Ornish program, you know, is one of these things out of UCSF, and I heard that St. Jude he's listed on their website as being one of the 4 in California, but I can't seem to find anybody over at St. Jude. Are you aware of anyone that's doing the Ornish program there?
No, but I mean, you can get any qualified dietitian to, you know, to instruct you on how to pursue a good vegetarian diet.
Okay, appreciate it.
Well, thank you so much. It was a great evening.
Thank you. You know, he always does such a great job, and we very much appreciate you traveling here to see us.